I'll turn it over to Dr. Santora. Dr. Willis is not here. He has taking a well-deserved time off, and happy to have Dr. Santora, who has been a big partner in our effort to respond to COVID appropriately.
Good morning, supervisors. Thank you, Matthew. You can jump ahead to the next slide. I come bearing good news today. You can jump to the next slide. Thank you. We are seeing significant decreases in COVID-19 activity in our community. This is due to our high rates of vaccination across the county. We are leading the state in this rapid decline of this fourth wave because we are the most highly vaccinated community. That being said, human behavior is predictable, and you can see that uptick in activity. This is our post-Labor Day increase in cases that was expected to be seen. So we are anticipating a second little hump that hopefully will be self-limited as families and students return to their regular activities for the next couple of weeks as they focus on school and work. So you can jump to the next slide. And the additional good news is the success that we're seeing is resulting in a reclassification by the Centers for Disease Control. We're no longer in the old blueprint framework. We are now shifting towards following the Centers for Disease Control framework, and we were the first county on September 6th to enter into the moderate phase. That being said, we're tracking very closely because we are approaching case numbers that could push us back into the orange or substantial transmission category. It really depends on how active Marin County residents were during this Labor Day weekend and mixing with both vaccinated and unvaccinated crowds. If you look at although we're in yellow, that is still comparable to what we considered our old purple tier. That was anything above 7 cases per 100,000. What is most concerning to us is we continue to see a very high case rate, 28.5 cases per 100,000 among our unvaccinated population, and that's what's continuing to have COVID activity in our community. We also see the increase in cases that I reported about the post-Labor Day uptick is seen more dramatically in the unvaccinated population because they are 5 times more likely to be infected. Vaccine still offers significant protection against disease transmission, so it's not unexpected to see the increase in case rates being driven primarily by our unvaccinated population. You can jump to the next slide. Importantly, we follow 2 factors. We're looking at the overall health and well-being of our community, but we're also looking at our hospitalization rates and protecting our hospital and healthcare system. So we have seen an increase in cases who are currently hospitalized consistently in Marin County. 90% of cases are occurring among unvaccinated persons. I say commonly that the hardest part of my day is looking at who's in the hospital and seeing that the majority of those hospitalizations would have been prevented by vaccination. We are seeing unvaccinated residents underestimate their risk of severe disease. And unlike the past, when we saw the majority of hospitalizations among our greater than 75 years old population, we are seeing hospitalizations in the 30 to 50-year-old range. So this is one of our deepest concerns. It's also concerning just because we do only have 3 hospitals in our county who provide services. We are concerned about maintaining access to those services for regular bread and butter life events that happen to us as we navigate a pandemic and are still aging and face issues like heart attacks and strokes. And so when we have our hospitals beds filled with preventable hospitalizations, it's concerning. So this is something we will continue to be following closely. We will anticipate this to lag for 2 weeks from the peak, and the length of that lag really will depend on that post-Labor Day uptick in cases among that unvaccinated population. Can jump ahead. And just to remind everyone, the data that Dr. Willis and I share is all available on our website. That's where we pull all of our data from so that the community can track what we're seeing. So everyone's hearing a lot of news around our booster clinics or booster shots. It's in the news based on some federal communications. We see the role in public health as unique than what the role that we experienced before when we had to develop plans and implement mass vaccination efforts to vaccinate our very vulnerable community in January of last year. Boosters are still under evaluation and consideration by the Food and Drug Administration and the Centers for Disease Control and our own California Department of Public Health. But we see the primary role for booster vaccines being in the healthcare space itself. So we are expecting all Marin County healthcare providers who offer regular vaccinations for shingles or flu and otherwise, they should be providing their eligible patients with the COVID-19 booster vaccine when authorized and recommended. That being said, we're setting our public health goals on a performance goal to make sure that 1 month after approval, that the wait times for booster appointments for the population greater than 65 years old is less than 2 weeks. So again, this is not an emergency to get your booster shot. We're continuing to see from our own data locally and nationally that our vaccines are proving very effective at preventing severe disease. And so that is why we will be waiting for additional guidance on how we roll out our booster planning in the community. That being said, we are prepared, we call it to enhance the offerings of boosters in our community. We are an older community, so if and when the FDA provides and the CDC provide recommendations for boosters for older adults 6 or 8 months after their first series, then we are prepared to support the healthcare system by offering enhanced clinics throughout the county. So there'll be more to follow in the upcoming weeks on these enhanced booster offerings. You can jump to the next slide. So I already talked about this a little bit. Our priority populations really continue to be our most vulnerable. We've learned a lot from this pandemic over the past 1.5 years, and public health will be focusing on booster clinics for our most vulnerable. So that is going on site to nursing homes across the county and also providing access to boosters for the greater than 75 population who we have seen in the past when there were no vaccinations. That was the population that had the highest risk for severe disease and hospitalization. We're working hard to establish private and public partnerships with Safeway, Rite Aid, Walgreens, and other entities, again, to make sure there's sufficient vaccine access in our community. And we are currently supporting our healthcare providers build their capacity so they can offer vaccine clinics, the COVID-19 vaccine in their own clinic. So patients can go to their own doctor to get the booster shot. And that includes technical assistance and even assistance with storing the vaccine, where the county will store the vaccine and providers will be able to come and pick up. And we've been doing that throughout since probably about March this year. We've had a system for providers to pick up vaccines from us and provide vaccination in offices. So we have some great providers in the community, private practice providers that are already providing COVID-19 vaccines, great pharmacy partnerships, and we look to strengthen those to make sure eligible individuals will have access to the booster shot. Jump to next slide. A role we see much more significant for us as it relates to pandemic response is the COVID-19 pediatric vaccines. Just like with booster shots, we are trying to build capacity for all of our healthcare providers who offer pediatric vaccines to provide vaccinations to their patients in their clinic. But again, this is a critical, important population. It's one of our largest reservoir of unvaccinated individuals, and that's a greater risk for continuing COVID-19 activity in our community. So we will be prioritizing our public health resources to support the pediatric vaccinations in our community. We are not anticipating the pediatric vaccine to be approved until late October of this year. That being said, we'll be ready to launch with support of our Office of Education and the Medical Reserve Corps to launch pediatric vaccine clinics as early as October 28th. We will be going on site to schools, as well as having what we call our Super Saturday events, where we have larger events to ensure we reach the goal of 75% of newly eligible children will have received their first dose within 1 month of authorization and recommendation. Jump ahead. So schools, one of the accomplishments I'm most proud of is the reopening of schools. We have been firmly committed since the summer of last year that schools are the best and safest place for students to be, and our data has shown that. And so we're really proud of those efforts. It's taken a lot of work, and really fortunate to have very strong partnership with all of our school districts, private and public schools, and most notably the Marin County Office of Education. We're a joint team that is focused on keeping all schools open and classrooms open and reducing the educational attainment gap that we knew widened during this past 1.5 years. We're working with the Office of Education, California Department of Public Health, and Marin Health to expand school-based testing. We call this our rapid response testing, where when there's an exposure event. So a person who is infected is known to be on the campus and have undetermined close contacts with other students or staff. We're working to come on site to provide testing 5 days afterwards to support something known as modified quarantine. So this allows students who may have had an exposure in the school environment to stay in school rather than being quarantined out of school. And the reason we're able to do this is because we have policies like universal masking and that are proving to be effective at reducing the risk of COVID-19 transmission in the school environment. We are also piloting home-based antigen testing. So the vision is that every student in Marin County would have a home-based test. So if they develop symptoms, they can get tested right away at home, or if they are part of a known exposure and placed on quarantine, they also can be tested at home to support them staying in school. So this is a pilot. It's been slowed down. There's significant shortages nationwide in access to Binax antigen testing. So it slowed down our role a little bit, but we're still looking forward to gaining steam and making sure that we can have more access to testing countywide to, again, decrease the risk of someone being infected coming onto the school campus. The most common entry point that we continue to see is unvaccinated symptomatic persons reporting to school, both staff and students, when they shouldn't. If anyone has symptoms now that are consistent with, sounds like a sore throat or allergies, you should assume it's COVID until proven otherwise, and that's whether you're vaccinated or not, and that's due to the levels of COVID activity in our community. We updated our 32, was a 30-point plan. We had anticipated before Delta that we go down to a 10-point plan, but with Delta, we updated it to a 32-point plan and develop different levels of mitigation. So we started with a much more conservative approach because of the findings from our own research around an outbreak related to the Delta variant in our school community, and strongly recommended that all schools implement a policy requiring outdoor masking. It significantly reduces the possibility of unmasked close contacts and allows kids to stay in school and facilitates our contact tracing efforts. I also discussed that we had our expanded testing, and then we also issued updated guidance around sports and performing arts, which has a recommendation for testing for unvaccinated students that are engaging in higher risk activities. Jump to the next slide. So one of our principles since the beginning has been being transparent in our data and being data driven. So this is our most updated dashboard. And I know the numbers may look big, but they actually are less than expected considering how children are attending school right now and with the Delta activity that we're seeing. And I'll have a comparison, a year-to-year comparison on the next slide. But right now we have 119 exposure events. So these are staff and students who came onto the school campus, most either symptomatic or asymptomatic, and were identified as being infected they were at school during their infectious period. So with all of those exposure events, we have a team of contact tracers and a schools team. We also have public health liaisons at each school who work with us to identify if there's been any close contacts in the school environment and to make recommendations whether they should be quarantined because they're a close friend who's had out of school contact, or if they can continue attending school with modified quarantine. Notably, you'll see most of the identified transmissions are student-to-student transmissions. That's occurring among unvaccinated students to unvaccinated students. We did have one case of a staff-to-student transmission. It was, I think, our first case since we've reported data, and was not surprising to us just due to the younger age of the child who was infected. So you can jump to the next slide. The other information before I go on is that we'll be reporting on the vaccination rates among staff and among students. So the community will be able to see how vaccinated our schools are. So you just look for my year-to-year comparison. Last January, when we had 739,000 student days, first to note, it took us into January to get over 700,000 student days. Whereas now this year we are approaching 700,000 student days by September. Our world was very different last December. We were under a stay-at-home order. We were still navigating the blueprint tiers where we were unable to go to restaurants. So there was very limited social activity. Last year, when we only had about 17,000 kids in school, those students who were in school, most of them were on a hybrid learning model where they were only attending school 2 days a week and they had 6 feet distancing. This year, we do not have physical distancing minimums. We have universal masking. I have almost 40,000 students in school in person, full-time, 5 days a week. So it's obviously very different environments and higher potential for exposures this year compared to the last year. And you'll see that even with that, we have comparable levels. We actually have less exposure events on campus. And that's primarily due to also the ability of staff to be vaccinated and the protections that vaccines are offering staff. And we have comparable suspected school transmissions. We're considering adding a new category called undetermined, because our community is so wide open. When we do investigate cases and we do offer testing on site, sometimes we find incidental cases where there's no connection to the student who or staff who originally tested positive. So we're considering a new categorization called undetermined, where we're not able to identify where the student or staff may have acquired the infection. You can jump ahead. So just to close, we are gaining a win from our high vaccination rate and are seeing the 4th wave ending, but we are preparing for a post-Halloween 5th wave. We're hoping for it to be a much smaller, shorter 5th wave. Human behavior is predictable, so history does repeat itself. And what we saw last year as the temperatures cooled down, we have a lot of Halloween parties and activities in our community. People move indoors and start celebrating, and that's where there will be increased risk for COVID activity. Especially, we will not have any child between the ages of 5 and 11 fully vaccinated before Halloween. So it takes weeks to achieve full immunity. It's 2 weeks after your 2nd dose. And so we have to be prepared for a fall where the majority of our kids still will not have a full immunity. We are seeing waning immunity among the vaccinated group of our community. And so we are seeing breakthrough cases consistently. We also need to be prepared for new variants, and that might influence that peak of that potential 5th wave. That being said, we will be one of the first communities that really will have the opportunity to shift from a pandemic response to learning how to manage endemic circulation. We're going to have probably among the highest rates of vaccination in the world in Marin County, and that will offer us significant levels of protection. A lot of that we do have some vulnerabilities in our community because as we shift to endemic circulation, we will still see new variants emerging from under-vaccinated communities that might be able to thwart and evade our vaccine and the immunity that we developed due to vaccination or the natural immunity that we developed for those individuals who were infected with COVID-19. We're still recommending universal masking indoors. That being said, Marin County is one of the Bay Area counties that has a mandate. We're meeting with the Association of Bay Area Health Officers this week to develop consistency of thresholds for when we would shift away from a mandate for indoor masking. So there'll be more to follow in the next week or so. What will be those thresholds when counties consider ending the mandate? It's important to note that we implemented a mandate when universal indoor masking was recommended. The reason why we implemented that mandate is we consistently saw unvaccinated persons enter into indoor public spaces without a mask, even though the recommendation was for them to be masked. And so I would not anticipate that if a mandate were to end in Marin County, that the recommendation at the state would change and that we would expect that universal masking to stay in place, especially as other counties across the Bay Area are not seeing the reductions in cases like we are seeing in Marin due to lower vaccination rates. We strongly recommend everyone also get their annual flu shot. I think this is also portends what COVID will be in an endemic space where people will be making a decision every year about getting their annual COVID shot. But right now we're recommending everyone over age of 6 months to get their annual flu shot. This is a very different time than last December. We did not see significant flu last year because everyone was hunkered down. We are now living in a very open community. We're seeing strep again, we're seeing other viral illnesses. So we absolutely are anticipating higher levels of flu this year. And even at our best last year, I think we only approached 60% of our population getting their annual flu shot, when there was honestly a lower risk for getting infected with the flu. This year, you'll have much higher risk of getting infected with the flu, so we're recommending that vaccination. And then just to take the opportunity to catch up on your other vaccinations that you may have not had, especially pneumococcal. This is the vaccine to protect you from pneumonia if you're over the age of 65 years old. That's another risk for us, is if we have COVID-19 activity, if we also have flu and pneumonia circulating in our community, we threaten the stability of our healthcare system by having limited capacity in our hospitals and ICU. So that's it. Happy to field any questions from the public or the board.
Thank you, Dr. Santora. Going to bring it back to the board for questions. Supervisor Conley.
Yes, thank you, Dr. Santora, as always, for providing complete information to the public. I think you've largely answered my questions this morning, but perhaps a couple follow-ups. You spoke about the future of vaccine distribution in Marin and some of the public health goals in that regard. Can you speak to whether those that receive the J&J vaccine will be handled differently than those with the Pfizer or Moderna vaccine?
We don't know is the answer right now, but what is happening and why there was a delay in a recommendation from the CDC after its August meeting for consideration of boosters was that they recognized the need for more data to look at the performance of all three vaccine types that we have, Moderna, Pfizer, and the Johnson & Johnson, and to look at studies that are occurring globally around those vaccinations and mixing vaccinations, for example. So what we are anticipating is from the CDC in October that we would get complete guidance on how individuals should consider boosters based on the vaccine type that they received. So that will be information forthcoming. We will be looking to the data and research and to see how those vaccines are performing. We are seeing breakthroughs in all three vaccine types. That being said, we see Moderna does appear to be performing better than Pfizer and Johnson & Johnson, but that is from local data and gathering of state data. And this is why we depend on entities like the Advisory Committee of Immunization Practices, where they're doing a meta-analysis of all the research that's available to provide the best recommendation based on the type of vaccine you may have received and also the timing of the vaccination that you may have received. So more information to follow.
Great, thanks. We'll look forward to that. You spoke about the situation in our hospitals in Marin and some trend lines there. A couple follow-up questions. Do you have a sense of how many hospitalizations are of Marin residents?
We don't have an exact number, usually between 2 to 5 of the hospitalizations that you see on a daily basis are maybe from out of county. We are not seeing right now transfers like we saw in the past during the January wave or our third wave of COVID-19, when we saw surges in, for example, Kaiser system itself, where they were transferring patients from Roseville into Marin County because they didn't have capacity in some of their regional medical centers. What we're seeing right now is that counties are transferring patients within their own county system. And so the experience that we're having in Marin County around hospitalizations is not consistent across the Bay Area. Alameda, Contra Costa, Santa Clara have hospitals that have much significant higher levels of hospitalizations right now, but they're able to manage the distribution of their patients within their county, the county themselves. Typically what we see is someone might be traveling from out of county into Marin County and get hospitalized. That's why we might see a couple of those hospitalizations, but it's not out of county. We also closely follow activity in San Quentin. So it's also a very vulnerable population. And if boosters are needed for vulnerable populations, that would be one other population we need to consider, as well as we want to protect our healthcare system. There's older inmates at San Quentin and who could be at greater risk for an adverse event in the future if they do not receive that booster shot. So that's something we'll also be closely following. And that's the impact we saw in the summer of last year, is that we had a high number of hospitalizations due to persons who are incarcerated at San Quentin.
Great, thanks. And you kind of anticipated my next question. Taking a step back, what is happening at the regional level with the other Bay Area counties? And perhaps you can touch on hospitalizations, but also other metrics. And as part of that, how's Marin doing, relatively speaking?
We're a good bunch of overachievers, and I think we all should be really proud of our pandemic response efforts. If you look at every single metric, Marin County is at the top in vaccination rates, lowest case rates in the state, lowest hospitalization rates in the states, lowest deaths in the state. So I'm really proud of our response. We look at performance metrics to make sure we are contacting all of our cases as quickly as possible in order to make sure that they can isolate quickly and quarantine quickly so we can decrease that possibility of transmission in our community. So we're faring much better than I think most counties in the state. When we look at the region, the other counties that are part of the Bay Area are larger counties often and have more diverse populations and have pockets of under vaccination, which is why you'll see some of the regional medical centers be more impacted within one county, really driven by the vaccination rate of that particular area or community. And so what we do within our own county, and this is what we do with our hospital partners, is if capacity is reached at one hospital, we'll work first to transfer patients within our own county. When ABAHO meets this week, that's the Association of Bay Area Health Officers, we'll be looking at regional hospitalization data as we consider removing that mask mandate. We do think the mandate was a contributing factor for some of the rapid declines that we saw in the Bay Area, not just before masking itself. I think it indicated that this was a much more significant surge and Delta was different. And so we also saw an increase in vaccination immediately after the mandate was recommended. So I think it's multifactorial why we're seeing decreases in cases so quickly in Marin County, but vaccination is definitely one of them. And we believe the masking contributed to that. So we would expect to see mandates ending in different Bay Area counties, potentially at different times, but we hope to have consistency in the threshold. So if someone lives in Solano or someone lives in Contra Costa, they would understand why a mandate might still be in place in one community, but not in place in another community. And again, just to reinforce, we're not expecting when the mandate ends that the recommendation is going to change. The recommendation would still be for universal indoor masking. So I think that's where I hear the community in my inbox saying, well, the mandate should end. That doesn't change the recommendation. The mandate was issued because the recommendation wasn't being followed.
Thank you.
Supervisor Moulton Peters.
Let's get this going. Thank you, and thank you, Dr. Santora. I just had a quick question about the definition of the word endemic circulation that was on one of your slides. Thanks.
So a good example is the 1918 flu. Just a quick history lesson. It was we call it a novel virus that emerged, caused severe death in a large, severe illness and death in a large population, started circulating very rapidly across the world, and hit levels where you're dealing with a global surge of activity, of disease activity. Think flash forward from 2018 to flu is no longer a novel virus that caused a pandemic. It's something that we know is constantly circulating across the globe. We know we've learned in the past 100 years when we're at highest risk for illness from the flu, that's in the winter season. And so that's why the majority of us in Marin get our annual flu shot to prevent from severe illness, and why the public health role has been for decades to support vaccination in our long-term care facilities. So what we would expect with COVID-19 activity, especially after we are able to vaccinate that pediatric population, is that we'll have very low COVID-19 activity in our community, going back to the days almost like in May, where we had just a couple of cases a day because someone traveled, but it wasn't that COVID was circulating among our population and people were asymptomatic but infectious. And so that's the goal, is that we get to those low levels of COVID activity circulating. The reality in our globe, though, is that other countries with lower vaccination rates, and other parts of our own country with lower vaccination rates, other parts of our own state with lower vaccination rates, will have high COVID activity. And when there is high COVID activity, that's when the virus mutates. And so when the virus mutates, that's when, if we had a vaccine for for the Alpha variant, we're seeing it's not so effective for this Delta variant. And so what I would expect is in the spring of next year, scientists will be looking at what is the dominant variant that's circulating throughout the world, and then make a recommendation potentially for a seasonal COVID shot in the fall to offer protection to individuals from that variant. Especially the trick of the viruses is that when they mutate at exactly where our immunity is targeted. That's how they evade us. So that's the concern for something like the Delta variant. It had 6 mutations at the exact point where your vaccine was targeted. And so that's what viruses do. So as long as there's significant COVID-19 activity across the nation, across our state, across our nation, there'll be mutations, and then individuals will be making choices around their seasonal COVID shot. And public health will be, again, banging on the doors of people literally and figuratively to convince them that it's in their best interest to protect themselves and their families to get their annual flu shot and annual COVID shot. So, and I think that will be what it looks like until we can, to see if we actually can battle this on a global scale and reduce transmission significantly in the next couple of years. But you have to think of the globe and the billions with a B of people who remain unvaccinated and are in communities that are highly unvaccinated, where COVID will find its way. And and we are an international community. So we'll always have vulnerability for that for at least the next couple of years.
So it really matters not only what we do here, but travel and exchange with other communities around the globe.
And I think also globally, and thinking about climate change, and this is some of the challenges that we have. It seems like a jump from climate change to pandemic, but it's actually very closely related. We have higher risk of the viruses that we know can jump from animals to humans as we have transformations in our climate that force more people into urban settings. So this is part of our reality for years to come, just related to advanced industrializations and migration patterns due to climate change. So this is all of us interconnected at a global level.
And so endemic circulation means what? Ongoing circulation of the virus throughout our globe.
Like you would just point on the globe and do a sample of a population, and you're likely to find some levels of COVID-19 activity.
Thank you.